So I'd like to ask to give us a presentation about soft tissue injuries in tennis, and the presenter is Jan Lidstrom from Sweden. Am I correct?
That's absolutely correct.
Okay, thank you for coming, and the floor is yours.
Glad to see all of you in this lovely weather. You should be out playing tennis instead of being here listening, but let's continue anyway. So I'm an orthopedic surgeon, but I have concentrated very much. The last 20 years I've been a foot and ankle surgeon, and that's why I'm going to present most of the soft tissue injuries concerned to mostly the ankle. There's a lot of problem, of course, but I'll talk mostly about the ones that are clinically important. The ankle problems in tennis are, of course, acute problems, and there are chronic problems. And some acute problems will be chronic problems. That is, if you can't use them, treat them in the right way. So then it's much easier to treat the problem when it's acute than when it's become chronic. The acute problems is mostly ankle ligament sprains, and connected to that are sometimes ankle fractures. I'll talk a little about that because there is also a connection between ligament sprains and ankle fractures, and I'll also discuss tendon ruptures. When it comes to chronic problems, I'll talk about tendon rupture, about tendon luxation, about osteochondritis, and about soft tissue impingement. I just give you an idea of how important or how common this problem is. And the lower extremity injuries are much more common than in upper extremity, of course, because it's more loaded in the lower extremity. And in the United States, there is a number of 27,000 cases every day, so you can see it's quite a problem. And it's important that you can treat these acute problems properly. The foot and the ankle is from the beginning not bonely stable. There's a lot of doesn't work there, well, you can see. Yes, you see here, there's a lot of ligament between all the different joints. The joints are not anatomically fitting very well, so they are unstable if there are no ligaments. And the ligaments are working in most positions so that they keep the joint surfaces together and the foot will be stable. And when it comes to soft tissue troubles in the foot, it's almost always the ligaments that are deranged first, and which gives an instability to the foot, and that's why you have to treat in the first place the ligament apparatus. This is the lateral side, and this is the medial side. You see there are less ligaments on the medial side. They're strong ligaments, but about 90-95% of all ligament injuries in the foot are on the lateral side. Very few are on the medial side, so it's not so common to treat the medial ligaments. That's why I'll concentrate to talk about the lateral ones. And how does this sprain actually come? The mechanism in the foot is, it's not very light, this one. Well, it's an internal rotation of the foot and a supination of the foot that give rise to a big strengthening of the ligaments here. You have the anterior talofibular ligament, and you have the calcaneofibular ligament. These two ligaments are the clinically most important around the ankle. The posterior ligament down here, it's very seldom ruptured. It's the first one, either one of them or both. About 50%, both of these ligaments are torn. So if you have a internal rotation of the foot, it's obvious that It's mostly common with a anterior tibiofibular ligament rupture in this case. And if you have more of a supination, a combination between supination and inner rotation, in this case, you will have both ligaments torn. If you have only a supination and not so much of the internal rotation of the foot, it will be the fibulocalcaneal ligament that will be torn. If, however, the ligaments are intact, I mean, in young people or in elderly people, the skeletal, children, the skeleton is not mature, and in older people you might well have an osteoporosis, and that means that the ligaments are more often intact, and what happens is that you have a fracture instead. So the ligaments, they are intact, and the bone fractures instead. This is what you can see here on this picture. And here, small fracture lines. And this is what happens on the medial side. You have the strong medial deltoid ligament on this side, and when you have a pronation and outer rotation, you start with a rupture of the inner ligament, the deltoid ligament here, and when that ruptures and you still have a dislocating force, the next is the syndesmotic ligament in the middle here that ruptures, and when that one ruptures, you get a fibular fracture in this position. So you always have to think about the fracture or rupture change, starting with the ligament, and when the ligament rupture and the only thing left is the skeleton, then the skeleton will rupture as well. So when you have a patient coming in with a distortion of the ankle joint, so what's the clinic? The obvious thing, of course, is to look here. You see a big hematoma, a miscoloration, and your swelling of the foot. And observe that this is the end of the fibula, and here is the hematoma, here's the swelling. If there's a patient coming in with this kind of clinical picture instead, where you have the hematoma rather around the lower end of the fibula, this is much more suspicious of being a fracture than the other one when the hematoma is down here. Then it's much more, the ligaments are here, here, and here, so the hematoma will come here, and when it's up here, it's more obvious that it could just as well be a fracture. Okay, so how do you treat an acute ankle sprain? The most obvious thing when the patient comes in is a swelling, and if you are aware of that, the first thing you have to do is to try to diminish the swelling as much as possible, and the easiest thing is to have a bandage, and you have to tighten it rather much just to prevent the swelling from coming. You can use a cold pack that will not prevent the swelling, but it will give the patient less pain, which of course is good. You can also use elevation, and if you do an elevation of the foot like this, of course there will be less blood pressure. The distance between the ground and the foot means that the swelling of the foot is less. Rest is good, because if you rest the foot and the ankle, there will be less blood flow, and when there is less blood flow, there will be less swelling, of course. And when the acute situation is finished, you can always try NSAID to help the patient diminishing the pain. And what happens to the ligaments? The first thing that happens to a ligament is there's an elongation of the ligament, no tear, but an elongation of the fibers. After that, when the force goes on, there will be a partial tear of the ligament, and if the force is big enough, there will be a total tear of the ligament. However, there's been a lot of studies looking at the treatment of this, and for all three of this, functional treatment is the optimal way of treating the patients. No operation is not necessary. If there is a problem with instability in the long run, you can operate the patient until 2 years after the injury, and the results are just as good anyway. So we never start doing surgery on patients even if there's a total rupture. We treat them with a functional treatment. And that includes that they have some form of an orthosis to make them less painful and make them able to exercise. And the exercise that we use is mostly for a force platform where you can strengthen the ligaments and still protect the patient with a orthosis. The patient here doesn't have an orthosis, but it's just to show how it's done. So it's very important that you put strength on the ligaments, because when the ligaments are strengthened or lengthened during or put into pressure, elongation forces, the fibers of the ligaments will be orientated in a much better way. That means that the ligaments will be much more efficient in the future, because if you put the patient in a plaster, or if that just let them rest and put no force on the ligaments at all, that means that the ligaments will be less efficient in the future. So functional training from the first day is the absolute best way to make the patient happy. But even if you do that, of course, there will be chronic problems. All patient doesn't heal whatever you do. So some of them have a persistent instability, and they have a persistent pain. The instability could be of two sorts. There is a subjective instability and objective instability. Subjective instability is something that you, when you're a doctor and you're trying to test the stability of the ankle, you can feel only that it's stable. But the patient complains of instability feelings, give away sensations, and that it's caused because of an intra-articular reason. It could be a loose body, it could be a synovitis, it could be torn ankle meniscus. A lot of reasons for pain in the ankle joint gives rise to pain. And when the patient puts load on the ankle, there is a pain in the ankle, and it's transmitted through a reflex arch back to the bones, meaning that the muscles in the leg are released and that they have less contraction, meaning that the pain will lessens also. The pain never accomplishes any pain, but the patient feels only the instability, the give way phenomena, and no pain. So it's easy to confuse that with an instability of the foot. And what you do then, of course, is that you have to investigate why the patient does have pain in the ankle. So you have to do either an X-ray and an MRI or a CT or an arthroscopy to find out the reason for this pain. And that's one way to. Then, of course, you have to deal with the intra-articular pain. The objective one is, in a way, much easier. Then patient complains of instability, and you try the clinical ways of testing this. You have the drawer sign when you test the ligament between the fibula and the talofibular ligament. The drawer sign, and you can feel that very easy. then you're quite sure that I can help this patient by mending the patient's ligament. There's also what's called the talar tilt, that is the pronation supination instability test. As you see, you do it with 2 hands, and you can feel how the calcaneus is moved when you try to tilt it. And when these 2 clinical signs are there, you can move forwards to treat the patient clinically and surgically. And what you do is you try to repair the ligaments. You suture them. That's a normal method. The method I use is to drill boreholes in the fibula and try to shorten the ligaments, because they are almost always lengthened. It's a good and very reliable method of doing this. What we never use, but has been used in periods, is that you take parts of tendon and construct a new ligament from the tendons. This is the short peroneus tendon. The problem with tendons is that they have a tendency of lengthening over time, because the result for the first years is usually very good, but when it's come to long time results, the results are much less good, and that's because the tendons are lengthened, and also because you see this is the situation. This is where the ligament goes there, and here's the ligaments, but the tendon have another direction, and when the tendons does not have the correct position, then they will be much more exerted for more violence when the patient uses the foot, of course. So tendon ruptures, something we never do. And there are other causes of lateral pain from soft tissue engagement, and one of course is the peroneal tendon rupture. There's a peroneal tendon luxation, and there's impingement of the lateral ankle joint. This is the long peroneal tendon, but the rupture is usually the short peroneus, which is in front of the long one. And what you have here is the lateral ankle impingement. The pain is in front of the fibula. And you can distinguish it rather much, because the tender point is in front of the fibula here, and if you have a luxation, or if you have a tendon rupture, or a tenosynovitis or something, the tendinous is always located behind the fibula. So you see here, this is where you have the most obvious tendency for tenderness, and especially if you move the foot with an internal rotation and flexion against the patient is told to keep the foot still, but you move it with an inner rotation and a flexion, and the patient has more pain than it's suggestive of a tendon rupture. So this is how it looks in the most cases. It's a longitudinal tear, because the tendon walks over the end of the fibula down here, which is most of the times rather sharp, and that means it cuts it like a knife, like this. But that's a good rupture, because it's easier to mend. You just suture it and hope for the best. This is the easy way to do it. There are other ways you can do it, of course, depending on how this rupture looks, but this is quite a normal case. Then you have a peroneal tendon luxation. The peroneal tendons, they are kept behind the fibula by a retinaculum, and when that retinaculum is either teared, or usually the short peroneal tendon, it will come under the retinaculum, so it works out like a pouch under the retinaculum, so it lifts the retinaculum up and the tendon is displaced forward. In this case, in an easy case, you can see a swelling just on the top and in the front of the fibula, and in the most obvious case, it's hard to miss. Then you have the tendon coming all the way here. And then, of course, what you do is you make an incision, come in, you look for the retinaculum, and then you suture the retinaculum back to the lateral end, the dorsal end of the fibula. And the luxation also, it does have the same spot of tenderness over the end of the fibula, like this. And then what you do is try to keep the foot in the same position and dislocate it inward rotation, and then with a sharp or click it will come forward on the border of the fibula. Sometimes you can see on an X-ray a small and sharp ossification like this, and this is probably because of a bleeding when the first accident happened. But if you see that, you should always be aware that it could be a sign of peroneal tendon luxation. There are many methods of mending this. You could make a new peroneal retinaculum by using periosteum, or you can take a piece of bone and move it dorsally. But the most common problem is that the pouch under the retinaculum is where the tendon is displaced. So you just have to freshen the surfaces and suture the retinaculum back to the bone, and that will make this function very well. There's also something called lateral ankle impingement. You have the pain being in the front of the fibula. If you do make an arthroscopy, you will see that there are lesions inside the joint. It could be one of the syndesmotic extra ligament that's in the front here. It could be a synovitis, or something that expands in the joint and makes it more vulnerable to movement. So what you do then is that you have to get rid of the surplus of tissue, like the ligament here. So we just do an arthroscopy, go in and you just take it away through a burr or some instrument that you use. There are also osteochondral lesions. As you see here, there's a lesion of the top of the tails. And these osteochondral lesions could be due to either one big trauma or a number of small traumas coming. And it could be that you have a loose body in the joint, or it could be what's called the open gate, that you have a part of it still attached to the rest of the cartilage here, and this rest of it functions as a door. What you do here is that you do an arthroscopy, you inspect how it looks, and if possible, you try to mend it by having little bone needles or something just to put it back in place, and most of the time this works as well. Sometimes you have osteochondral lesions that you don't see on the X-ray, but the patient complains of locking episodes. The foot in some positions just is locked. They have the pain with that that the pain that the brain doesn't recognize, and we have instead the giveaway phenomena. You have joint swelling, you have the ankle pain, you don't feel any instability in the ankle, and then you have to think what could be wrong. Then you're not supposed to just be satisfied with this normal X-ray. You have to go on with more sophisticated X-ray method like a CT or an MRI. And here it's very easy to visualize, of course, that you have an osteochondral lesion of the top of the talus. And what you do here is in principle the same thing. You have to get rid of this loose body, and you have to clean the surface so that you don't have any loose fragments. And what you do when the surface is well done, you can through the arthroscopy use burrs and make burr holes into the bones. And when you do that, you can have osteoblasts that are inside the bone, and these osteoblasts come up on the surface, and on the surface they transform to be chondroblasts and later chondrocytes. So you hope to restore the cartilage in a normal way. It's not absolutely true that it does, because the normal stratification of the cartilage is not so often found in this way, but it works very well. The big thing is that you should mend this so that you have an intact surface, so that this injury will not propagate. If you do nothing, it will probably be bigger and bigger, and you will have a more intensive osteoarthritis coming. There are many methods of dealing with this. You have this Hangody method, where you take small pieces of bone cylinders from the knee and make burr holes in the ankle joint, and put these to form a surface as good as possible. But in Gothenburg we also tried this cartilage cell transplant since many years back, where we use cartilage cells from the knee. We do an arthroscopy, take out some cartilage from the knee, and then we culture it in a fluid medium. And after 2 weeks, we make an operation of the ankle joint, take some periosteum, and on this spot where you have the lesion, you suture this periosteum, and then we push or infiltrate the cartilage that we have cultivated under the lesion. So it's sort of a tent, and under the tent is all the immature and mature cartilage cells. So this is how it looks. Nowadays we don't use this method anyway. We rather have a mesh graft that we let the cells in what do you call it? The cells are in the mesh graft instead, and we can then put the mesh graft into the defect of the bone, either by a glue or by just putting it in and keep it there, and make the patient move the ankle as little as possible the first month. Yeah, that was some of the soft tissue injuries that you can imagine in the foot. Thank you.
Okay, thank you very much. So if you don't mind, it's the time for questions, and if you have them, so please ask. Yes? Okay. I will translate, okay?
Thank you.
Okay, he has 2 questions. First one is how to make the decision, do the surgery or go for the conservative treatment.
Regarding what? I mean, what? Do you mean ligament rupture? Yes.
Okay. Yes.
Well, It's in your hands. If there's an instability, then and the patient is not happy. I mean, if there is an instability and the patient comes more or less acute, we treat them with the functional treatment. And if the functional treatment doesn't work very well, we say we let them into a heavy physiotherapy therapy for at least 6 or 8 weeks. And if that doesn't work, when we start thinking, and if the patient have too much problem with instability and pain, yes, then we do the operation. But you know that it's only about 15 or 20% of the patients that we have to operate late. So the combination of an instability that you can feel with your hands and the patient's complaint, then you have to decide. And you have to give the patient, of course, the options that it will take some time to rehabilitate afterwards and so on. But we do it quite often, operations on these patients, because I'm working on the foot and ankle section of the clinic, so we see all the cases. So that's why I operate a lot.
Can I add my question to your topic? What is the time gap for suturing, for example, the ATFL? If we have this injury, yes, the acute injury, and we did the, let's say, MRI, we see the total rupture of ATFL. Yes. What is the time gap in which you can do the suture of the ATFL successfully?
2 years.
2 years. After 2 years, it's the less reconstruction. I mean that.
Yeah. Well, but I used the reconstruction. We have artificial ligaments. Sometimes the ligament is so torn and has been diminished even before the accident. It could be the reason for the actual rupture. Then I add this artificial ligament on the top of the one that I have suture, and that works very well.
Okay, thank you. And your second question? Poco. Patempimo ar plyšimo? Okay. What is your opinion if we have the case when we have the total rupture of the ligament? So what is your advice when we can start active movements after the injury? If we are not going to do the surgery?
Why shouldn't you be able to start the functional exercise? I mean, there's a reason why you can't start the exercise, because that's what we think is best. Don't operate if you don't have to. The body is much smarter than the surgeon, so it will heal sooner or later.
Okay, we have another question.
I have a question about tarsal tunnel syndrome.
Sorry?
Tarsal tunnel syndrome, when there is a tibial nerve compression. So how often does it occur after ankle sprain or ankle surgery after the fracture?
Well, my opinion is that you should be very cautious about operating these, because the results in the long term is not very good. It depends on if there's a compression of the tibial nerve caused by something in the tarsal tunnel, and you can operate that one. It could be a venous plexus or some tumor or something, then the results are good. But if there's an impingement of the nerve that's intraneural, that means that you have a scar formation within the nerve, then the results are very bad. And I operate less and less tibial in compressions because I get frustrated. The results are not very good. You should always try to persuade the patient not to do the operation.
Thank you.
More questions? Can I ask one more?
Absolutely.
What are the studies are saying about the development of the osteoarthritis related with the ankle instability?
I remember only a very old study from Umeå in Sweden where there were no connection between ankle fractures and ankle distortions and things. But I've seen later studies having some connections between frequent distortions and osteoarthritis of the ankle. But the results are opposing each other, so I'm not sure. I mean, you see a lot of ankle fractures, but you don't see that much ankle osteoarthritis. So it's not an obvious connection between them.
So, for example, if the athlete torn the ligaments and wants to be active and play without the ligament, feeling no instability, no functional instability, so we can say that he can successfully play without any kind of risk or small kind of risk of developing osteoarthritis in the ankle, yes?
Yep.
Okay, great news. Thanks.
Thank you.
No more questions? Okay, so thanks again for coming and big applause for the professor. He came especially for this presentation here.